Okay, continuing on with the physician RN on scene, that's been an SMO we've had for some time. There's really no change other than just the format of how you handle if a physician arrives on scene. Preeclampsia or eclampsia, again, primarily if it's eclampsia, a new medication that we're adding in this case that we can use if seizures develop. First of all, you would stop the seizure hopefully by sedating the person as you would before, but now we can add the mag sulfate in the case of preeclampsia. So that'll be a new medication that we'll be putting on the rigs. Trauma and pregnancy, again, primarily just format changes. No real changes in that SMO, so other than format. Acute pulmonary edema, again, the format's changed a little bit, but there's also some other changes. One thing, again, as mentioned in the chest pain, basics will be carrying nitro on basic rigs. So they, again, typically can do their first dose offline, or if they need additional, by that time they should be calling into medical control and that sort of thing. And CPAP and nitros continues to be your primary treatment with that, with the pulmonary edema. Lasix has been put in kind of with a caution, okay, that not all pulmonary edema patients are fluid overload. Actually, a good share of them may not be. So Lasix is only used if you have obvious signs of fluid overload. You know, another reason that typically people have real poor lung sounds in this time of year is what? Pneumonia. If we mistakenly give Lasix to the patient who has pneumonia, who is dehydrated, we can actually have a very bad outcome for that patient. So there's definitely more of a caution with the Lasix. Morphine was taken out, okay, because there's not a lot of evidence that morphine really does a whole lot other than maybe reduces their anxiety and that sort of thing. So again, the protocol itself then spells it out again that the nitros by the EMTs, and again, that caution with the Lasix. Again, our primary treatment here is going to be pretty much nitros and CPAP, generally with the pulmonary edema. Gynecological emergency, rape, sexual assault, again, primarily just format changes, not a little, so. Refusal of medical care and transport. A few changes on this one, especially when you read it and that sort of thing going over it. One of the things is kind of changing the terminology. Instead of is a person competent or not, what we're looking at is their apparent decision-making capacity, because that's really what we're deciding. You know, does the patient have apparent decision-making capacity? And we're looking primarily at what? Level of consciousness, are they orientated person, place, event, that sort of thing. You know, whether they're competent or not is more of a legal decision, you know, so we're looking at that. The other thing I think we really need to do, and the protocol actually goes into this, is we need to look at these refusals as high risk, low risk. I think if we survey EMS providers, I think that over the last however many years, we're probably seeing an increase in refusals for various reasons. And sometimes I think we take them maybe a little lighter than what we should. A refusal can be an extremely high risk type call when we take those. So, you know, yes, there are some that are low risk, you know. There's no injury, there's no, it's somebody driving by with 911 called and you got there. Those are not the ones we're concerned about so much. But we really need to do a quick assessment on that scene. Is this a high risk or this is low risk? If it's a high risk, we probably better do what we can to try to do an assessment. Again, the patient has to consent to do it, to do as much as we can and make that determination rather than just blanketly taking a refusal too quickly. We also have some discharge instructions that we can blanketly, you know, give some of these patients, you know, that do it. And the refusal form's just been added an additional line basically to where we can have a signature that they actually received those discharge instructions. The other one we have is a multiple patient form, you know, for larger events with multiple patients and things where it may not be practical to get individual refusals from every patient. So, and if you look in the SMO again, the suspected high risk, and those things are obvious, you know, hopefully chest pain, syncopal episodes, anybody who's had an altered mental, strokes, TIAs, you know, things like that, you know, abnormal vital signs. Like I say, we need to do an assessment if at all possible. Those are, you know, definitely high risk. You know, you get the person who passed out at church, had a syncopal episode. It may be nothing. okay? It may just be a vasovagal and may not be a high risk. It could also be what? A cardiac event. It could be a stroke and things like that. If we don't take, ideally, some time, do an assessment, and make some good decisions. So I really think we need to start looking at these refusals, high risk, low risk, to make that determination. Again, I understand we still have to get patient consent to do those things. Yeah. So, and then, like I said, there's actual discharge instructions, okay, that we can give the patient. So when they do refuse, similar to the hospital gives discharge instructions for various things. And again, this is a two-sided page, so it doesn't go into a tremendous detail, but it does give them some reference. And on the one side, it also then gives additional information that they can actually, call back, and they should if they have additional problems and that sort of thing. So that's, I think, important that we start using those. And on our refusal form, there's actually be a line that is added so that you can actually document that the patient has received those discharge instructions. Restraints, a lot of it is format changes with the addition of chemical restraints, that ketamine is now an option. We've had the Versed for some time, but now ketamine is actually an option for the restraint and that sort of thing. So when we look at that protocol, again, it may not be the first thing that we do, is chemically restrained, but it is an option that we consider it. Talk to the person, try to calm them down, and that sort of thing. The one thing I think that's important here when we start talking about sedating a person, is one of the things that's in our routine medical now is capnography. I think capnography needs to be used pretty routinely when we start sedating, because I think we all realize when we sedate a person, pain management, any of the sedation, a risk of what? Respiratory depression, correct? Capnography is one of our best tools to monitor a person's respiratory effort. And I just look at it medically, legally, if you have a problem, if you didn't use the best tool to assess your patient for that risk, how would you defend that if there was an adverse outcome with it? So again, it's not listed specifically, but it is in our routine medical. So I think we should that should be our standard. Okay. So seizures, pretty much format changes, no major changes there. So the sepsis. Sepsis is a new SMO, okay, that we're adding here. Sepsis can be a pretty major problem, can be a life-threatening problem, comes on pretty quickly in some cases. So it's a new SMO. There's actually a screening tool that we have, and if they are positive for that, then we should be activating a sepsis alert. Notify those hospitals early. With this protocol, we potentially can give, quite a bit of fluids depending on the patient's condition and that sort of thing. We usually start fluid channels like 30 milliliters per kilogram, basically. Again, pediatric patient with history of CHF, we probably need to reduce that a little bit. So we need to think about that. And if that is not effective, then we may have to consider dopamine to get their pressures up. So the other thing is EMS, I think a lot of us have focused when we talk about shock, for instance, with systolic blood pressure, and to a certain extent, sometimes EMS, I think we do the diastolic, but sometimes we don't pay as much attention to that. It's primarily systolic that we're looking at, which may not be the best thing. What we probably ought to be looking at more is our mean arterial pressure. That's going to give us a better indicator, of a shock state by looking at that mean arterial pressure. In the protocol, it lists the formula to figure that out. And when I do some Con Ed, I would bring that up. And when somebody has a critical patient, doing math is probably not high on their list of priorities. However, most of us are using non-invasive blood pressures, and the map is listed on it. And my understanding is the way most of these non-invasive blood pressures actually, the map may be actually more accurate than your systolic and diastolic. That when the non-invasive actually determine the blood pressure, it's really determining the map and then deriving the systolic and diastolic from that. So it's maybe more accurate when we're using automatic, and it's probably definitely more accurate to tell us when we need to give that fluid challenges and that sort of thing. So I think that's probably a little change we need to start thinking in pre-hospital as far as the mean arterial pressure. So, and and it's the same thing. Oh. And like I said, on the monitor, and there's even a picture of it, most monitors, right after your blood pressure, it's going to have your systolic and diastolic, and usually in parentheses after it or below it, it'll list your map. And it's surprising. Most people, when I talk to them, don't really realize what that number is, even though they may have been looking at it for years. Didn't realize that we had another tool that we haven't been using. Okay. The sepsis screening tool. Again, when we look at this, the top section is basically what? Somebody who is high risk for infection, somebody who is high risk for sepsis. So we have a patient, so if we check one of those boxes, it puts them kind of a high risk for infections, that sort of thing. And then we have some of our clinical signs. If they have 2 of those clinical signs, that's evidence enough to actually call in a septic alert. So whether it's the temperatures, the heart rate, things like that. And another one I think that is maybe pretty accurate is capnography. I know there was a study done in Florida that they're saying that according to a fairly large study, capnography levels below that 32, and that's how we came up with that, was actually almost as diagnostic for septic shock as when they did lactic acid tests at the hospital. So, it's again another tool that maybe has been underutilized. But I think here is, again, if we identify this, you call in early, as soon as we can, notify the hospitals. That just when pre-hospital calls in, STEMI alert, which will hold like this, I think it speeds things up at the hospital. Lots of patients come through the hospitals. When we give a pre-hospital alert, it kind of sends them to the head of the line and gives them some care quicker, hopefully. Okay. Hemorrhage control, shock treatment, sort of thing. So again, a little bit of format changes. Direct pressures are still by far our number one way of stopping bleeding. Tourniquets have had a much bigger increased role. Again, they're still limited how many times you're going to use it because usually direct pressure works. But if we get there, direct pressure does not work, you're not going to take much more time. Think of tourniquets if that is appropriate. The pelvic binders. Again, whether there's commercial devices out there or we can do makeshift ones with sheets and things like that if we have to bind that pelvis up a little bit, laying a person with a pelvic fracture on your stretcher or on the backboard and letting them kind of roll around on that board isn't going to stabilize it. And a pelvis can have a tremendous amount of bleeding. So those pelvic binders can be, helpful. Hemostatic agents, it's an option in the protocol. We kind of discussed that, well, not only hemostatic agents, but the IT clamps, if anybody's seen those or some people have used those. They are effective ways of stopping bleeding. We just as a region did not think that it was necessary to mandate those in all rigs, because I think if we go through a lot of ambulance services, if they went through the records, they'd probably find almost no times that they would use it. And to put these things that are relatively expensive, that are just going to sit there and expire, may not be the best use of our resources, But if you're in an area where it may be, you look at your history, you look at the type of calls, it is an option. So it can be utilized. Again, with the system approval, they're already in the regional protocols as an option, so not mandated. Again, fluid resuscitation, we're still using either. We're adding, again, traditionally it's been systolic blood pressure we look at. Now we still have that, but we're also looking at possibly that mean arterial pressure. And the other option that we have with this is a new medication is TXA for these patients. Primarily it's internal hemorrhage when we have a patient. They're tachy, their blood pressure is low, defined here less than 100, and it's got to be relatively quickly used. If the injury is over 3 hours, then we're not going to be using the TXA. It's going to be contraindicated in that case. Okay. So then when we look at that protocol, again, it starts out pretty much the routine things as we talked about. Control that bleeding, which is, again, extremely important to stop that bleeding. And there you can see how the hemostatic agents, IT clamps, are an option, not mandated. Fluids then, as next slide here. So we can give it the fluids uncontrolled. Usually we're looking at pressures below that 80 to 90 systolic, or like I said, if we have that mean arterial pressure, when it starts dropping, below that 65, that's where we really need to think about giving the fluids, okay? And that may be a more accurate gauge using that mean arterial pressure like we talked about in the sepsis, and using those same guidelines when TXA may be appropriate. Special needs patient, it's kind of a newer SMO. It covers different types of special needs, whether it's just communication barriers, which does happen fairly frequently. They have other adjuncts, even service animals we're addressing somewhat in here. So, again, if it is taking care of a service animal, basically, you got to be able to control the animal. Police dogs, sometimes that may be a concern, just because, they may be, whatever happened, may have that little dog a little excited and that sort of thing. So you got to be able to safely handle it and that sort of thing. The new law in the state of Illinois is we can actually transport a police dog or arson dog, okay? If it's injured in the line of duty, and the other thing is there has to be no humans that need treatment, So those still have to be our priority. If we do treat a police dog, we do the best we can. Again, there's differences in taking care of dogs, and we probably don't have a lot of training in that, but it's going to have to be transported to a veterinarian. The hospitals are probably not going to want you to be bringing a dog into their hospital. We just talked about that at the regional meeting, that there's some significant difference. So, really this needs to be looked at, is there a place you can transport a police dog 24 hours a day, So again, the special needs patient, another fairly big one. It gives some pretty good outline of trach care. That's happening more and more. Like I say, I think we see more potential for special needs patients. Patients who have health concerns don't always just end up in extended care facilities. They end up at home and things like that. And even if they ended up in extended care facilities, we still have a high percentage of calls where we have to transport them back and forth and things like that. So trach care, number one thing with trach care, of course, is suctioning, probably, to keep that airway open and patent. So that's number one care. Central lines, again, we have the option, like I said, under these protocols where we can access those central lines, so we can access them, but we also, look at them. If there's problems, bleeding, things like that, you might have to deal with it. Same thing, information on shunts that patients may have. So a lot of information here for routine treatments of these. There's our police dog. Okay. So I get more information on colonoscopies, that sort of thing, GI tubes, Foley catheters. Again, these are patients that I think, especially interfacility transport, sometimes we do quite a bit of these type patients. So the SMO gives us some more guidelines basically in dealing with these patients. And then there's a list of just format changes on these. Not a lot of treatment care. I know spinal restriction, that's a relatively new regional SMO, so that hasn't changed other than just a little bit of format. Same thing with the stroke, that was a fairly new one, so just format. Surgical crike has been around pretty much forever, so it's pretty much just format. The rest of these are the syncopal, the toxic events, pacing, and transfer care. So these are pretty much just updated to the new format. So, transport template, okay? Traditionally, we've had a protocol, it's a mandated protocol, or we have to have, according to the state, is for transporting to other than the closest hospital. The concern I've always had with this, and we brought it up in our discussions when we were working on this, is our region is large. It covers an extremely diverse type population. Here in Rockford, for instance, we have 3 fairly large hospitals. A majority of the ambulance right in this area are ALS. I live out in the boonies, out west. My closest hospital is a small community hospital. We have a lot of basic services and things like that. So to treat those all the same, how you should transport to the closest hospital may not be the best option, is what we started discussing. So we got into a big discussion on that, of how do we handle that to cover the different geographic areas, to come up with one policy. And we pretty much decided we really couldn't come up with one policy. So what we're leaving in place is the old closest hospital policy, and then we put together a template. So the template will actually go through each individual agency, will fill out a template. They will get what hospitals do they routinely transport to? What is their average response time to each of these hospitals? What is the hospital's care level, specialty care, and things like that. And then a determination will be made for that individual agency that, for instance, cardiac patients ideally should go here, trauma patients should go here. So once the agency works through that, it's got to be approved by the system. In reality, it'll probably be done in conjunction with the system to make this determination. So then it will actually get sent to IDPH, be added on as part of that system plan, that agency system plan, and then basically that's what their medical control, that's, you know, to decide how you're going to transport. So that can be customized for each individual agency. So it'll take a little bit of work for an agency to do this, but I think in the long run, we're going to have a better plan. You know, everybody is saying, I mean, a lot of these national organizations and things, that the closest hospital may not always be the most appropriate hospital, you know, and if we're just making this decision on the fly, which is kind of the way we're doing it now, I don't know if we're getting the best result, you know. So pre-planning it along with the system medical director, I think will be a better result, hopefully. So arrest, trauma arrest is just format changes on the SMO, no real content changes on that. VFib, pulseless VTAC, again, a little bit of format. Again, with the H's and T's, primarily what you talked about with what asystole and some of the other ones, H's and T's we consider now in this case is what, mag sulfate, particularly if it's torsades, you know, magnesium sulfate may move to the front. And if we're suspecting what, hyperkalemia, as we mentioned before, calcium gluconate. So it's two additional medications that we'll consider under those H's and T's, the causes of the arrest. Okay. And again, just looking at the protocols, you know, that we can see here. Again, treatment for VFib primarily is still what, good high quality CPR and defibrillation every 2 minutes. You know, that is still the main treatment for VFib, good high quality CPR and defibrillation, you know. But then, like I said, in addition to the EPIs and the antiarrhythmic that we've had for some time, we can now consider, depending upon the causes, depending upon your assessment and that sort of thing of your patient, mag sulfate for some patients with a polymorphic VTAC, and then the calcium gluconate for hyperkalemia, that sort of thing. It also mentions here that if you have a perfusing rhythm, so they were in VFib and you got them back, you can make a determination whether you want to give them an antiarrhythmic. Before, that was in the protocol, but was what? You're supposed to call in and get medical controls authorization. This is offline protocol now, I can say, that we consider whether we need a antiarrhythmic, okay, depending upon whether you've given it before or not. Okay. Wide complex tachycardia, okay. Again, consider the adenosine. Adenosine is usually, what, narrow complex tachycardia, but sometimes we can have aberrant conduction, so it might be appropriate. As I mentioned earlier, it needs to be primarily in regular type rhythms. You know, adenosine is not something we should probably use in for the AFibs and that sort of thing, so it's a regular rhythm, but it's a consideration. American Heart Association basically says it's almost a diagnostic procedure. That if you have one, you're really not sure whether it's VTAC or SVT with aberrant conduction, you can try adenosine. If it worked, it was what, an SVT. Okay, if it doesn't work, then you're kind of leaning toward VTAC or the wide complex. Okay, so again, the same thing, lidocaine or amiodarone for these are actually offline. In the old protocols, you had to call in, you know, if the patient had a perfusing rhythm, if they had a pulse. So those are offline now. If it's polymorphic, I'm saying VTAC, but wide complex polymorphic, again, the mag sulfate may be indicated, so we would consider that. There's appendix to this. Basically, it gives us, again, what we've had for some time, which is the acceptable abbreviations, okay? And that's one of the things we still sometimes see, and I think all the systems, I bet if we surveyed, that sometimes if we review some of the charts, we can find some very unique abbreviations, you know, and we really should be only using approved abbreviations. So that's it. Rules of 9, Glasgow Coma Scar, AVPU, you know, a sample history, all these things our reference material, basically. A big one that has been lately is the medication shortages that we can do this. What we're trying to do in some of these cases, and some have been pre-approved, is have some backups already in the protocols. That we can, I think Kurt may address that a little bit. Yeah, here will, because when you have a medication shortage and you can't get it replaced, it's probably going to be what, on a Saturday night, and nobody open and trying to make a determination. So we can actually have some backups that we can consider to go to have it kind of pre-planned. Because this medication shortage is becoming what, more and more of a problem, it seems like, and it's rotating, and it's what changes almost day by day. So we're trying to come up with a little bit of way of handling this. Our primary assessments, these are things that we can do. Again, reference material, secondary assessments, field triage criteria, so medical control criteria. These are all things that were in the protocols, but it's probably not a main treatment. It's more of a reference material that we can have, maybe used in classrooms and that sort of thing. So the other part that Kurt will be going into more here in a little bit is the medication charts. And, one of the things with these medication charts is when I've gone out, I've started doing a little bit of in-services with some agency that I'm finding is one of the things you will notice as you start looking at it, you are given more leeway probably in decision making. We're trusting your decision making, okay? And I think that one of the important things is because I can doesn't always mean I should. Because I can give this much doesn't mean I should. Some cases we should give a slow, reassess, and make a determination, But it does give you the leeway in critical situations. You may be able to go to higher doses rather than you have the critical patient who, for instance, still seizing, and your 10 milligrams of Valium didn't work. Under the current protocols, you're supposed to call in. That's not the person you probably want to take the time to call in. So you'll see you'll have more leeway with these protocols probably, but you have to think. So.